In this session, of course, we will going to discuss the NEET PG 2024 questions. Let us start with this new question which came. What is this 𝐍𝐄𝐄𝐑 criteria for ventilation? So actually it is based on carbon dioxide, and they can ask in this session, we will not just discuss the question, but we will try to discuss the whole topic so that if they ask the question in further exam, we should be prepared. So first thing is that according to this criteria, there should be 3000 cubic feet space per hour per person for proper ventilation. How they come to this number 3000? Actually, the carbon dioxide which we expire is around 2 part in 10,000 part of air. So if you do 2 by 10,000, it will come out as 0.0002. This 4 will go there and it will be 0.002 cubic feet of carbon dioxide. But what we need per hour is around 0.6 cubic feet. So we need 0.6, and this is the need for ventilation, and this is what we expire. So when we divide 0.6 with 0.0002, then it comes as 3000 cubic feet air. And this is the air which we need if we want ventilation to be good. But this standard of ventilation is no longer followed. What we follow now is air change. And based on this criteria, there should be around 3 air change in 1 hour. If it is more than 6, there will be too much of dryness. And the air which we need is, we need around 1000 to 1200 feet cubic feet per person space for proper ventilation. So it's not 3000, it's 1000 to 1200 according to this air change criteria. Okay, so that was 𝐍𝐄𝐄𝐑 criteria. Now, one more thing they ask similar to it is, in occupational health, the space given to each worker is 500 cubic feet, but only 14 feet above their head is counted, not more than that. Similarly, here also you can see height in excess of 10 to 12 feet are not counted. So we only count 14 feet above his head. And when they talk about a school health program, in a school health program, the space is 10 square feet per student. Okay. Now, a question which was wrongly answered by many of the very good teachers also was that if this is the plate which you have, and these are some food material which is there, which food material will be giving you maximum thiamine? That was the question which a student said. Maximum thiamine will be coming from which? And a lot of teacher I saw, they answered it as rice. But the correct answer, if you look at PARC, they have, in the recent edition of PARC, they have written it clearly in this table that wheat is around having 0.45 milligram of thiamine per 100 gram. So wheat is having much more than rice. If you look at rice, it is only 0.21. And if it is milled rice, it is again 0.06. So why people answered it as rice? Because we all know the concept that if we are eating polished rice by removing the upper husk layer, then thiamine deficiency can occur. So that is a correct concept, but the maximum amount is not in rice, it is in wheat. And if you look at other things like, let's say, curd or cow and other things like milk and curd, it will be very less as compared to wheat. So if they ask one answer, the correct answer will be wheat. But then some student, they recall that both are in the option. If both are in the option, then there is no confusion, rice and wheat will be correct. But if one option they ask, answer will not be rice, it will be wheat. Now, the third question was that a farmer came with complaint of calf muscle tenderness, headache and conjunctival suffusion. So which disease he is suffering from? He is definitely suffering from leptospirosis. But the question which they can ask further is it anicteric leptospirosis or is it icteric leptospirosis? Okay. So what is the difference? In the icteric leptospirosis, these all features which we just discussed will occur: calf muscle tenderness, headache and conjunctival suffusion. Actually, it was a direct line from this part. It is icteric leptospirosis, which is more severe than because it in this the patient have jaundice, then fever, myalgia, and these 3 symptoms. But if it is anicteric leptospirosis, that is a milder form, there will be fever, chills, myalgia, conjunctival suffusion, headache, renal manifestation will be there, and some pulmonary manifestation can also be there. Hemoptysis can occur. Okay, so this either decrease or disappear within 2-3 days, and then after anecteric, patient may go into icteric, in which jaundice will also develop. Okay, so I hope you will remember it. And then leptospirosis, if occur during pregnancy, it can also cause fetal complications, fetal death, abortions. And one more thing you have to know is that it can lead to pulmonary hemorrhagic syndrome also, and case can go there. For the diagnosis, we do culture if it is between 1 to 6 weeks, and then we do dark field examination of patient blood by culture. Then from urine, we can take it from 10th day to 6 week. Okay, urine can be used for diagnosis during that period. Next question is, a 5-year-old boy with diphtheria came to clinic. What should be done for his 2-year-old brother who is fully vaccinated till now? So this was a question again which different teacher gave different answer, and I had the privilege, because I am recording it the last, so I went through all the discussions, and the correct answer is again better understood by looking at Park textbook. So Park has written it directly that to the contacts, if they say that primary immunization or booster dose was received within the previous 5 years, no further action would be needed. And in our story, the child who is less than 2 years is getting the primary immunization. Primary immunization has been given, and the age is 2 years, so it is definitely less than 5 years. So that is why the correct answer is that no further action would be needed. But if the primary vaccination or booster is taken more than 5 years, in case of more than 5 years, we give booster dose of diphtheria toxoid. And if it is non-immunized close contact without immunization, then only we give prophylactic penicillin or erythromycin. So if somebody tell you that we give penicillin to everyone irrespective of immunization status, that is the wrong thing, because Park has clearly written less than 5 years, no intervention, more than 5 years, DT toxoid, and if unimmunized, only then we give penicillin or erythromycin. These are for the contact. Now what we do with the case, suppose they ask in the next exam, what will you do with this 5-year-old boy? For this 2-year-old boy, what is the thing which you have to do? Because he is fully immunized, we will do reassurance and we will not take any further action. But what will you do for the 5-year person? For the 5-year, we will treat, and treatment depend on which type of illness if you have. If it is mild illness, then 20,000 to 40,000 unit for mild. If it is moderate, 40,000 to 60,000. And if it is severe, then we give 80,000 to 1 lakh. And then in addition to antitoxin, every case should be treated with penicillin or erythromycin. So the people who were saying that we give penicillin, erythromycin to everyone, they were saying it for the case, not for the contact. सबको पेंसिलिन और एरिथ्रोमाइसिन देते हैं इलाज में, बचाव में नहीं. जो घर के बाकी मेंबर हैं उनका इलाज इस क्राइटेरिया के बेसिस पे होगा. कॉन्टैक्ट विल बी फॉर द अदर पीपल, एंड फॉर द पेशेंट, फॉर माइल्ड इट इज 20 to 40K, for moderate it is 40 to 60K, and then for severe it is 80 to 1 lakh. Okay, and along with this, whenever we are treating the patient, we will always give erythromycin plus penicillin. Okay, now all the carriers should get 10-day course of oral erythromycin. And if they ask you the drug of choice for diphtheria or pertussis, any two disease, then for both of them the answer is same. Drug of choice is erythromycin. As you can see, it is written here also, but erythromycin is drug of choice in adult. They have asked this same question in NEET exam last year, that in children what is the drug of choice for diphtheria or pertussis, then the answer will be azithromycin. Okay, both diphtheria pertussis follow the same antibiotic, but in diphtheria we give antitoxoid also to contact, who are the patient, to contact we give antitoxin, but only if last immunization is more than 5 years. Only then we give the toxoid to contact. One more question they ask is that true false type question has been asked in NEET previously, that the dose of diphtheria toxoid is more in adult or more in children? So you can see it that 2 Loeffler's diphtheria toxoid is for adult and 25 Loeffler's is for pediatric. So adult get less toxoid. How much? 2 Loeffler's of DT, adult. But children get around 10 times more. Adult less toxoid, children more toxoid. Okay, children get more toxoid. More. And around 10, I can say it is 12 times more, 25 Loeffler's. Okay. Chalo, now coming to the next question. This was again a new question. What is this longevity dividend? Is it more aging lead to more disease? Intervention which will cause delay in related disease while aging? Is it multimorbidities with long life which will develop with long life? Or is it concept where aging will cause delay in related disease? So which is longevity dividend? To answer such question, one common knowledge we have to have is dividend simply means bonus. For example, we might have read it earlier, demographic dividend or demographic bonus. Demographic bonus come when dependent people who are less than 15 or more than 65 are less and earning population is more. Whenever the dependency ratio decreases, डेमोग्राफिक बोनस इज देयर, है ना. जब भी निर्भर लोगों की जनसंख्या कम होगी तो देश के लिए अच्छी न्यूज होगी, डेमोग्राफिक बोनस कहेंगे उसको, है ना. सो बोनस इज ऑलवेज ए गुड न्यूज. लॉन्गिविटी बोनस, व्हेन द कंट्री विल गेट लॉन्गिविटी बोनस, इफ वी विल डू समथिंग टू डिले द डिजीज इन देम, then their healthy life will prolong, and in their healthy life they can be productive and they can contribute for the growth of the country. लॉन्गिविटी डिविडेंड का सीधा मतलब है कि हम बुढ़ापे में होने वाली बीमारियों को कम कर दें, तो उसकी वजह से लोग हेल्दी लाइफ लंबे समय तक जिएंगे, और जब वो हेल्दी लाइफ लंबे समय तक जिएंगे तो वो देश के लिए प्रोडक्टिव हो सकते हैं, कुछ काम धंधे से देश में इनकम जनरेट कर सकते हैं. तो यानी लॉन्गिविटी डिविडेंड क्या है? वो इंटरवेंशन जिससे डिले होगा रिलेटेड डिजीज में वाइल एजिंग. ओके, क्योंकि ये गुड न्यूज है. बाकी सब देख लो, बाकी सारे बैड न्यूज है. ऑल अदर आर बैड न्यूज. मोर एजिंग, मोर डिजीज, दिस इज बैड न्यूज. मल्टीमॉर्बिडिटी विथ लॉन्ग लाइफ, दिस इज ऑल्सो बैड न्यूज. कंसेप्ट वेयर एजिंग विल कॉज डिले इन रिलेटेड डिजीज, एजिंग विल नॉट कॉज डिले इन डिजीज. वी विल डिले द डिजीज that will lead to healthy aging. That is longevity dividend. And the definition was originally being given by the person who devised this term, who coined this term, is that longevity dividend are the gain. These are the gain, good news, that can be realized if increase in life expectancy are matched by health improvement in how we age and changes in our individual behavior and social norm so as to achieve healthy, longer, purposeful and productive life. Okay, so we are changing in how we age. We are giving good condition of aging, and it can bring longevity dividend. One more thing is, it can be an example of there are terms like health and like DALY is disability life year, HEL is healthy life expectancy at birth, है ना. Sullivan index is life expectancy minus DALY, and then there is also QALY, quality year of life added due to an intervention is QALY. So if we are doing some intervention which are adding quality year, then that can also be, this longevity dividend is an example of QALY. देखो QALY, what does it mean? QALY simply means years of quality life added due to intervention. For example, dialysis add 0.5 QALY each year in life of patient. So if we do dialysis, we add 0.5 quality year in the life of patient. So whenever intervention, some intervention is giving quality health, quality life, that is example of QALY, and that is longevity dividend can also be an example of QALY. We are doing some intervention to prevent the disease which occur in old age, which is giving quality life to old age people. Okay, So do remember longevity dividend, and it can be asked again. Now, in a mother deliver in a rural area under guidance of a skilled care attendant, which of the following is incorrect regarding care provided by skilled care attendant at birth? So it was again one question which can be solved with common sense. We do clear eye, we cover baby head and body because 75% of heat loss occur by head, okay, from head. So we have to cover the head for sure. And then we start breastfeeding as early as possible, but we never bath the baby immediately. We take around 1 week to give bath to baby. After 1 week, we bath the baby. We can wipe her, but not take bath. And there are some of the things which you should know. We have to do delayed cord clamping, because by delayed cord clamping, 10 ml of extra blood will go, and therefore we put the clamp when the pulsation of umbilical cord stop. When it comes to the care of the eye, as I said, we clear it, and we can also put silver nitrate solution 1% to prevent gonococcal conjunctivitis, or we can see tetracycline 1% also in that. And if there is ophthalmia neonatorum, which is most commonly caused by chlamydia trachomatis. Trachomatis cause ophthalmia neonatorum most commonly. And in these cases also, application of topical neomycin might be more useful if it is ophthalmia neonatorum. And when it comes to the care of the skin, first bath is given after temperature stabilization, preferably after a week. So we don't give bath immediately, that's for sure. Let's come to the next. A fruit farmer present with fever, respiratory difficulty and neurological complications is there. And the student have told that in the image there was also a fruit bat hanging there. This image was also there. So which disease is there? Definitely it is Nipah. Both Nipah and Hanta, they have the origin of fruit bat, and both of them are category C, bioterrorism agent, newer agent. And the only difference is Hanta is transmitted by rat and Nipah is transmitted by date palm sap or pig. And so even in my last day when I was giving 30 important questions, while discussing bioterrorism agent, we draw this image that there will be tree, date palm tree and bat flying around, and then there will be pig. That will definitely be Nipah. Ebola and Marburg, both are category A bioterrorism agent, but they cause viral hemorrhagic fever. That means in Ebola Marburg, patient died due to internal bleeding, not due to respiratory illnesses. Okay, so they are there. Now let's discuss some more point about Nipah. One thing is it is of the family Paramyxoviridae, genus Henipavirus, and it was first isolated in Malaysia. Then it is also occurring in Bangladesh, and that's why it is known as Nipah. A place there was with the name of Nipah was there. And do remember it is with infected bat, infected pig, or from other Nipah virus infected people. Okay. So example is consumption of raw date palm sap contaminated with infectious bat secretion. Date palm sap का मतलब होता है ताड़ी, कल, which many of you must have also tested. In southern part of India, it is drinked culturally also. In the morning time, without fermentation, it is normal fruit drink. And this fruit bat, during their breeding season in rainy time, they like to drink it more, mahal banane ke liye, to set their environment and do the sex. So that's why it is transmitted through date palm sap, and that's why it is mostly transmitted in rainy season or post rainy season. Okay. So remember, incubation period is 4 to 14 days, and in the clinical manifestation, there will be fever, headache, myalgia, vomiting, and sore throat. And then it will be neurological symptom will also be there, like dizziness, drowsiness, alternate consciousness. Neurological signs will also be there. Okay, and sometimes seizures and encephalitis features will also be there, definitely. So these are the symptoms which will occur. Case fatality rate is 40 to 75%. That means if, let's say, 10 people develop it, then 4 to 7 out of them can die, and a very high case fatality rate. But the highest case fatality rate is of course for rabies. Okay. So now let's move to the next question. The next question is, in Ayushman Bharat under school health services, which one is not included? So we all know that in no case we give IFA monthly. So IFA monthly is definitely not included. But still, we should know what are the things which are included. So there are total 12 things which are included. One thing is we do health appraisal of school children, but it is not done by doctor. So there is no doctor who will do it. Usually there is trained teacher who will do the health appraisal of a student, who will also screen children for low visual acuity. So teacher is the one who is doing all this work. Other than health appraisal, they will treat them and ask for follow-up. There will be prevention of communicable disease, healthful school environment, nutritional services, first aid, mental, dental health, eye health, health education, education of handicapped children, and proper maintenance and use of a school health record. And now some schools are also distributing sanitary pad. Okay. So these are the 13 work you can say which are done under school health program. And now school health program also come under Ayushman Bharat. Previously only PMJ, Pradhan Mantri Jan Arogya Yojana, which is 5 lakh insurance scheme was coming under it. Then there was Health and Wellness Center, which are sub-center, and PSC will be renamed into it. And then school health program. All the three comes under Ayushman Bharat. And Ayushman Bharat is funded both by central and state government. When it comes to the tablet dosing, if they ask it about adolescent will get blue tablet of dose 60 and 560 milligram iron and 500 microgram folic acid. But when it is adult with hemoglobin 13, that means normal hemoglobin, non-anemic, then they will get once a week red tablet in non-anemic case. But if they are anemic, suppose they say adult female with HB equal to 9 in place of 13. So if it is 9, they will get 2 tablets per day. For prevention, we give 1 tablet per week in adult, 1 tablet per week, adult female, non-pregnant. But for treatment, we give 2 tablets per day. And when it comes to the pregnant female, of course, we all know in pregnant and lactation time, we give 1 tablet per day for 180 days before delivery, 180 days after delivery. But when it is for treatment, then in pregnancy also we give 2 tablets per day, same dose, 60 milligram iron, 500 microgram folic acid. But if this is the treatment for mild anemia, if the person have moderate anemia and she is coming late at pregnancy, let's say 34 week, then we can start with giving 2 tablets. But if she is not responding with it and she is coming late, then we can go for IV iron sucrose or IM ferric carboxymaltose injection. This question has also been asked in the past. And if she have severe anemia, then we directly go for blood transfusion. These are all part of 6x6x6 intervention of Anemia Mukt Bharat. I hope you remember. But some treatment part in gynae also they ask. So this part is important to discuss. Now a friend sent report of his brother, family doctor, saying that brother examined some occupational disease in which corpoporphyrin test is done. What is the problem here? The problem is plumbism. Plumbism, which is also known as lead poisoning. And in plumbism, there will be basophilic stippling. RBC will have basophilic granules. And there will be Burtonian line as well. There will be blue lining on upper gum. So these all are suggestive of lead poisoning for sure. We can see for lead poisoning, we do corpoporphyrin in urine. And it should be less than 150 microgram. Second thing we do is aminolevulinic acid. Aminolevulinic acid should not be more than 5 milligram. Third thing we do lead in blood and urine. And lead in urine should not be more than 0.8. And blood level should not be more than 70 microgram. And then there is basophilic stippling, in which inside the RBC there will be basophilic granules. So do remember those parameters of lead poisoning. And do remember, most common route of lead poisoning is inhalation. Is the most common route of poisoning. And drug of choice for lead is plumbism is ethylene diamine tetraacetate edita. Now in this question they have asked that which of the following disease have maximum submerged portion of iceberg. This part, lower part, is maximum in which of the following illness? So in tetanus and in rabies, along with tetanus, rabies, in measles also, in neonatal rubella and in pertussis, in all these 5 illness, there is no hidden part. Now, of course, if you apply the logic, suppose I am bitten by a rabid dog, then after 2-3 weeks, or let's say after 3-4 months, I will also start barking. There will be rabies symptom in me. So, but till that time of, let's say, 3 months, I am also hidden. So why I am saying that rabies, measles, neonatal rubella, pertussis and tetanus, they don't show iceberg phenomena? Because in these 5 illness, there is no subclinical case. Subclinical case means those cases which recover without symptom. For example, let's say coronavirus, COVID. In COVID, many people would recover without symptom. Only when they go for RT-PCR, then they come to know that they have corona. So in these 5 illnesses, subclinical case was not there. No one recovered without symptom. If I develop rabies, maybe I will be hidden for 3 months. But after 3 months, I will definitely go to some clinic. And when I will go to clinic, then clinician will report me. I will be in the apparent case. So no one recover in rabies without symptom. Similarly, in tetanus, no one recover without symptom. Measles, no one recover without symptom. And these 5 illnesses do not show iceberg phenomena because they don't have subclinical case. So these options are ruled out. Now we have chicken pox and influenza. So let's see which has more submerged portion. More submerged portion means which has more subclinical case. In which disease people recover more without symptom. So of course that will be influenza, because in influenza many people, they do not go to hospital. They recover without much symptom. They are in the subclinical hidden part. But chicken pox, people will develop symptom mostly. So let's see what is written there. Of course, this is the iceberg phenomena. Symptomatic case, which clinicians see, and pre-symptomatic, which PSM people see, because they are going door to door and searching for hidden case. That's why. Now, if you look at the influenza part, these strains has been found, and they have asked which strain is not being found. So H2N2, S3N2, H1N1, these all has been already cause epidemics and pandemic. And you can see that the source of infection of influenza is a case or subclinical case, and during epidemic, a large number of mild and asymptomatic infection occur. So they have written in PARC that a large number of cases are subclinical, asymptomatic. Now, when it comes to chicken pox, in chicken pox, you can say the source of infection is usually a case of chicken pox. It's not mostly hidden. The virus occur in oropharyngeal secretion and lesion of skin and mucosa, and rarely the source of infection may be a patient with herpes zoster also. Okay, so that means they have not written that in chicken pox many cases are hidden or asymptomatic, but in influenza they have written many cases are hidden. So who have maximum submerged portion out of these? Answer will be influenza. Out of these 4, that has maximum subclinical case who will recover without symptom. Okay. Now next question is, a female present with 22 weeks of pregnancy and she is pregnant after rape. Which statement is correct regarding MTP? So in the Medical Termination of Pregnancy Act, I hope you all know that previously only till 20-week abortion was allowed, but now under new amendment, between 20 to 24 week, 4 type of cases are allowed to go for abortion. Of course, one is rape, other is incest. Incest means family member did the sex and then pregnancy occur, that is incest. Then the third is of course contraceptive failure, and the fourth is congenital anomaly. So for these 4 illnesses, we allow to do abortion between 20 to 24 weeks. Now they can ask the question that out of these 4, in which criteria we can allow abortion even after 24 weeks. So even after 24 week, if someone want to go for abortion, then it is allowed only for congenital anomaly, not for other illnesses, other issue, but for congenital anomaly, even after 24, you can go there. So now let's choose the correct option. MTP can be done up to 24 week in this case. Yes, this is correct. And between 20 to 24, if someone is doing it, we don't need one doctor permission, we need two doctor opinion. If it is between 20 to 24, we need two doctor. If it is less than 20 week, then one doctor is sufficient. 20 to 24, we need two doctor. More than 24, we need permission of the whole team. And many students, they say they have asked it that who are the member of MTP team. And if you have to decide for MTP after 24 week, who will be in that team to decide? So we will come to that. MTP can be done after 24 week, not for rape. It can be done for congenital anomaly, but not for rape. And between 20 to 24 week, only done if it is life-saving to mother. No, we can also do it between 20 to 24 week if there is congenital anomaly. And in case of congenital anomaly, it's not life-saving for mother, but it prevents the fetus from unwanted problem in his or her life. So it's not always for life-saving to mother, it's for other reasons also. Now let's discuss this act in a bit more detail. First, let me tell you who are the member of the team. So if the medical board is being formed, this was one of the question, actually I should have written it in a separate way. If the medical board has been formed, there will be a gynecologist, pediatrician, radiologist, three people, pedia, radio, gynae, and then other member notified by official gazetted of state government as the case may be. So there are four members. One is by authorized by government of union territory, or state or union territory. Second is gynae, pedia, and then radio. Second, third, and fourth. These are the member of the team. Now, one more thing is, if there is a pregnancy which has not attained the age of 18 years, or who having attained the age of 18 years but mentally ill, then whom will you take permission from? That question also come. So in that case, you will be taking the permission only in written from the guardian. If let's say a 17-year-old girl came with her boyfriend and asked for abortion, will you do the abortion by taking the consent of boyfriend? Answer is no. We need parent consent in written to do that abortion. Okay. And of course, as we discussed, we do the abortion for these all reasons. If it is not 20 week, then we can do it based on one opinion. If it is 20 to 24, then we need two doctors' opinion. A lot of questions are coming in recent exam from MTP Act, so do remember it. A man presented with bilateral non-inflammatory edema after consuming a particular oil. This is oil. Which oil? They are talking about mustard oil. And in mustard oil, beautiful yellow color field, you must have seen that yellow color weed, Satyanasi they call it, Argemone mexicana. And this Argemone mexicana weed, it also have the same black color seed as mustard. So sometimes it get mixed naturally, sometimes they are intentionally being mixed to lower the price of mustard oil. So how will you detect for this adulterant? Nitric acid and paper chromatography, both tests are done, but if they ask the best test or the one test, answer will be paper chromatography test. Let's see it directly from Park again. In case of epidemic dropsy, other than pitting edema, there can be also be dyspnea, cardiac failure, and death. And some patient may develop glaucoma also. Okay. Now, first test is nitric acid test, which is a simple test. We will add it and the color will change to orange red if the mustard oil have sanguinary poison. But nitric acid is positive only when the level of argemone oil is around 0.25%. But if we do paper chromatography test, paper chromatography is most sensitive test. It can detect argemone oil up to 0.001% in all edible oil and fat. So if they are most sensitive, it is definitely paper chromatography. But nitric acid also we can do in this case. And remember the poison is sanguarine, the poison over epidemic dropsy. So, epidemic dropsy. So how will you remember it? S is for sleeping. And we are talking about dropsy, epidemic dropsy. So, if suppose you are sleeping together with someone of your dream, if you sleep, on sleeping, there will be dropping of the eyelid. And the symptom here is also bilateral pitting edema. So the symptom is also dropping inside, pitting edema. Okay. The second poison, which is confusing, why I am elaborating it here is, with a lot of time we get confused in the poison endemic ascites and epidemic dropsy. Ascites means there is swelling of abdomen. We call abdomen in Hindi pet. And the poison is pyrrozolidine. So that is pet. P for pet swelling ascites and P for pyrrozolidine is the poison. Now, just like here they have asked the test for epidemic dropsy, they can ask for endemic ascites. How do we prevent it? So for the preventing of endemic ascites, we can remove the Junjunia plant, because endemic ascites occur when Junjunia get mixed with Panicum miliare. Okay, Panicum miliare is mixed with Crotalaria seed, and poison is pyrrozolidine. So we can prevent them the mixing, plus we can do sieving of millet. Sieving of millet and separate sowing can prevent it. Then for this, one more thing is aflatoxin. If you want to remove, aflatoxin is there in groundnut, maize, a lot of crop, aspergillus flavus fungus grow, and which can lead to hepatocellular carcinoma due to aflatoxin. So if aflatoxin prevention need to be done, then we should keep the moisture content below 10% to prevent hepatocellular carcinoma by aflatoxin poison, okay, which can occur with, as I said, groundnut, maize and other crops. If it is ergot poisoning, which is the toxin is ergotoxin, black color ergot develop, and it mostly develops in bajra, rye and sorghum crops, and that can lead to cyanosis or necrosis of finger. So if you want to prevent ergotoxin, we have to do air flotation or hand picking. We have to remove those crops which has black color ergot on it, by hand picking or by air flotation. Because if you force air on the crop, that crop which has ergot, that will be heavy, they will fall nearby to the fan. But those wheat, let's say, or rye which are without ergot, they are light, so they will float to longer distance, and you can remove the black color ergot crops with other, you can remove them. And similarly, they have asked it in previous NEET exam that in neuroletharism, patient will be walking with crossed leg, on toe people are walking. What is the drug which you will give to prevent it? We will give vitamin C 500 milligram to 1000 milligram. Okay, 500 to 1000 milligram. And neuroletharism is of course by the poison beta oxalyl amino acetate, BOA, beta oxalyl amino acetate. Now, which phase of disaster cycle is included in recovery phase? So, recovery phase include triple R: response, rehabilitation, reconstruction. These three things are included in recovery. First, we will do the response and we will try to rescue the people and treat them. Then we will give them some job. Rehabilitation means making them self-dependent, giving them some job. Which job we can give? We can give them the job of reconstruction. And this three will make the work of recovery. So recovery have both 1 and 2, response and rehabilitation. And if you go it by Park, they have given it very simply: response, then we will give them the job, rehabilitation, then reconstruction, all is recovery phase. Now they can twist the question in next exam. They can ask mitigation and preparedness, which of the following come under risk reduction? So risk reduction phase before disaster include mitigation and preparedness. And these three, they are included in recovery. So to remember it in a go, I always discuss this mnemonic that let's say triple R, and the movie gang, they went to MP after their movie got successful. And they went to Ujjain in MP. And when you come out from Ujjain, on the left-hand side in the street, there's a big shop which give you bhang, the marijuana crushed leaf with dry fruits and all. And they call it thandai. So let's say they went to MP after for celebrating their movie success, and they took bhang, and they drink marijuana. So after marijuana drinking, there will be impact now. So that is the cycle of event. Response, first response, then we give them the job, rehabilitation, which job? In reconstruction, we will give them the job, and then mitigation, preparedness, and of course, whether you are prepared or not, there will be next impact. So like that, this cycle will keep on going on. So one question was this, and in the another session, they have asked the correct order of disaster management step. So of course, there will be impact first. After impact, there will be response, rehabilitation, mitigation. This is a correct sequence, of course, option A. Okay, because after mitigation, we do preparedness, MP, remember? So this is wrong. After mitigation, there is preparedness, so this is wrong. After mitigation, there is preparedness, so this is also wrong. Okay, so you can answer this question if you remember that mnemonic also. A man occasionally eat outside the home, and due to traveling reason, he present to a physician with abdominal pain of 4-day history, with fever and bradycardia also. So this is typically suggesting of typhoid. And in typhoid, in the first week, of course, we go for blood culture. Then after blood culture in the first week, we go for antibody test, Vidal test. And then there is stool culture in the 3rd week. And then there is urine culture in the 4th week. And that's why they remember the mnemonic BASU. Okay. And it's written in here in Park also that if we are looking on antibody or Vidal appear on day 6 and 8, 6 to 8. So it is after 4 days, after 1 week. 2nd week is for Vidal, and first is for blood. Blood culture is the mainstay of diagnosis of the disease. Okay, antibody appear on 6th day, and H antibody appear on day 10 to 12 after. That's why antibody or Vidal is in 2nd week. Okay. Now, the next question was based on parametric, non-parametric test. And to decide which test to apply, we use 3 simple steps, and you will never be wrong in deciding the test. The first simple step is you have to decide whether the data which we are using is quantitative or qualitative. This is the one slide which I took from my guest paper. In the quantitative data, there are those data which can be measured. Like we can measure cholesterol, bilirubin, height, weight, BP, we can measure. These are quantitative, and the result come in mean. Qualitative are those data which can only be categorized. Like if I say about my obesity, you cannot measure it. You can only say कि मोटा तो बहुत मोटा है, फटेगा थोड़ा मोटा है, mild, moderate, severe. You can categorize it. Similarly, if I ask about hypertension, hypertension is quantity or quality? Hypertension can be mild, moderate, severe. It cannot be measured. What we measure is BP. So BP is quantitative, but hypertension is categorical or qualitative. So simply remember, whenever we talk about disease, all disease are categorical, all disease are qualitative. And qualitative data comes in median and mode. Qualitative data comes in percentage or proportion. For example, I can say that in this class, how many percentage of students are anemic? So you can say 5 out of 50 are anemic or 10% are anemic. So whenever we talk about percentage or proportion is for which type of data? Qualitative data, which can only be categorized. So all disease, percentage, proportion, median, mode for qualitative, and what we can measure is quantitative. And whenever they give you qualitative data and there is 2 or more group, we will directly apply chi-square test. So if they talk about, let's say, obese, non-obese, anemic, non-anemic, mild, moderate, severe anemic, anything which is categorical and more than 2 group, we will apply chi-square test, simply done. Now let's come to quantitative data. In the quantitative data, in the question, if you found that test is done before giving drug, after giving drug, they measured the weight. Let's say you found a new drug to reduce my obesity and you gave it to 100 people and you measured their weight before giving drug, after giving drug. So if you are giving drug before, after, then both the weight are coming from the same group of participant now. In the same participant, you measured the weight before and after. So they are matched. They are coming from the same participant. They are dependent. They are paired. That's why we apply which test? Pair t-test. And sometimes they also write match data. Match data means, let's say you are giving your new drug to reduce obesity in 32-year male. So you will also give the previous drug orally stat, let's say, in the same age group, 32-year male. So 32-year male new drug, 32-year male previous drug. You are matching them before giving the drug. That is match data. So if you have in the question pre-post data, match data, husband-wife data, twins study, or study on the different body part of same patient, like if you are testing a new eye dilator with propicamide, you are giving new drug here and propicamide here, it is on the same patient. So this is again data which is paired or matched. So pre-post, before, after match you found in the question, answer will be pair t-test if the data is quantitative. If it is 2 group and the data is measurable quantitative, then we apply unpaired t-test. An unpaired t-test is also known as a student t-test. It is also known as independent t-test, because now the 2 group are not dependent. There are different 2 groups. So 2 groups, we call it unpaired student or independent t-test. And if it is 3 or more group, we call it ANOVA. Full form is analysis of variance. So simple thing to understand here, by which 95% question can be done, is if the data is qualitative, more than 2 group, chi-square. If the data is quantitative, pre-post, before, after paired, 2 group unpaired, 3 or more group, ANOVA. Now let's come back to the question and see what they are asking here. They are saying a study was undertaken to establish the consumption of vegetarian and non-vegetarian diet with disease. So first of all disease are qualitative. Second thing is, there is 2 groups, vegetarian, non-vegetarian, and they are trying to know which will develop more cancer, let's say colon cancer. So which test you will apply? Answer will be definitely chi-square test. When will you apply paired? If they say that we are establishing consumption of vegetarian and non-vegetarian diet with BP in place of disease, let's say they said BP before and after eating veg and non-veg. So then answer will be pair t-test. When do we apply correlation? We apply correlation to know the relationship between 2 variables. Let's say they want to know the relationship between BP and amount of non-veg eaten. Okay, let's say like this, some association came, eaten per day. So whenever you want to know the relationship, that is correlation, and this type of plot is known as a scatter plot. And we apply student t-test if in this same thing we are measuring BP of 2 group, veg and non-veg, but not before, after. We are just measuring it after eating veg diet, after eating non-veg diet. What are the BP of 2 group? Answer will be student t-test. So I hope you understand this concept and you can do this type of question. See, in this question, what is there? There is 2 group of newborn and we are checking their weight based on whether mother received food supplement or not. So we are checking their weight. Weight can be measured, and if we can measure it, it's quantitative, and there are 2 groups, so answer will be student t-test. Okay, it was not in the exam, it was just one PYQ which I practiced. Now let's come to the next question, which was similarly framed, that there is group of 80 people to study the effect of diet modification on cholesterol. So you have to always focus on the outcome variable, what is coming out. This is outcome variable. And can you measure cholesterol? Yes, we can measure it. So outcome variable is quantitative. If it is quantitative, then chi-square can never be the answer. Okay. And plus in the question you can see they have written the word pre and post. After giving diet, before giving diet, what is their cholesterol level? So before and after written, so answer will be paired t-test. Now what is this McNemar, sign rank and all those tests? See, test can be broadly classified into parametric and non-parametric. And I hope this part is clear. Why answer is paired? Because pre-post we are measuring cholesterol level. Now what is parametric, non-parametric simply means? Parametric are those tests which we applied if the distribution of data is normal. And non-parametric we apply if the distribution of data is skewed. If it is skewed, we apply non-parametric. Like this is positive skewed curve, this is negative skewed curve. And in the parametric, usually it is for quantitative data. And therefore, all this paired, unpaired, jet test is the same thing as unpaired t-test. Only thing is jet test when sample size more than 30, unpaired when sample size less than 30. And ANOVA. All these 4 tests are example of parametric. So sometimes they ask which is parametric, which is non-parametric. You can simply answer these 4 are parametric. Now what are non-parametric tests? It depends. One non-parametric test is definitely chi-square test. Chi-square is for categorical variable. Whenever you have 2 or more than 2 group, you can apply chi-square. But it depends whether the data is paired or the data is unpaired. Paired data means, as I said, if they have pre, post, before, after or match data, it is paired. So in the paired data, they can apply sign test or Wilcoxon rank sign test. Or they can also apply Friedman test. And in the unpaired data, they can apply McNemar. McNemar is only applied for dichotomous. Like let's say yes, no, anemic, non-anemic, male, female answer is coming out, then we can apply McNemar. And the second test is Mann-Whitney-U test. Mann-Whitney-U test. Mann-Whitney-U test. The third test, which is similar to Mann-Whitney-U test, is Wilcoxon rank sum test. This time it is not sign but sum test. And the fourth is Crussell-Wallis test. So how to remember it? Simply just remember that parametric tests are these 4: paired, unpaired, Z and ANOVA. And in the non-parametric, I used to remember it like this, that someone give you a sign, someone blink an eye towards you, give you a sign. After getting the sign, you become paired. You are no more a free man. So sign and free man are paired and rest are unpaired for unpaired data. Okay. So these are the tests. In some other session, I will describe in which condition we apply which test and all. Now they ask the question on PQLI, which can get confusing. All the criteria of HDI and PQLI, they get mixed. That's why they ask it again and again. And we again and again forget it. So let's read it in a way that we never forget it for the rest of the life. How? First thing is LI can be written as L1. It is written like that. So in LI, there is life expectancy at 1 year. Second thing is P stand for poor country, like India and all. So in poor country, will you measure literacy rate or you measure literacy rate for highly developed country like England? Of course, in England, bachcha English bol raha hai. When the child is speaking English, literacy rate is for poor country. So the second criteria for PQLI is literacy rate. Okay. Third thing is, in poor country, is it good to measure per capita income or is it good to measure per capita income in country like Russia? See, for India, we all must be knowing that according to Oxfam report, 2% Indian population have 90% of wealth of India. Rest all of us, 98% population are living on remaining 10% money. Only 2% family have 90% wealth. So if you include those rich people in India, then our per capita income is a bit okay. If you remove that 2%, our per capita income will go boom, under the ground, very low. So per capita income doesn't matter for a country like India because it all depends on those 2% people. For poor country, we measure infant mortality rate because IMR is the best indicator of, this question came in last year NEET, best indicator of accessibility and affordability of healthcare system. Accessibility and affordability of healthcare system. And it is also the best indicator of impact of ASA work. Try to understand this thing. You might have seen video of people taking pregnant women on blanket, on bed across river for treatment. Because in tribal areas and some village area, hospitals are not so good. So if accessibility is not there, अगर आसपास अस्पताल नहीं है, accessible नहीं है, जा नहीं सकती है मां, तो ज्यादा बच्चे मरेंगे. If hospital is not nearby, not accessible, IMR will be more. So who will tell about accessibility or affordability of healthcare? Infant death. Who will tell about ASA work? IMR. That's why in PQLI for poor country we measure A, B and D, and which is not PQLI component. Gross national product is not component. So now under HDI, what are the component? Under HDI, first component is of course life expectancy at birth, 1 year PQL1. Second is in education we took two criteria, mean year of schooling and expected year of schooling. Yeah. Not literacy rate because HD is for highly developed, PQ is for poor country. And then we measure gross national income per capita in terms of purchasing power parity, because the value of money is different in different countries. So with the same amount of dollar, how much thing I can purchase in India as compared to how much thing I can purchase in Nepal. That is purchasing power parity in terms of gross national product. So these are the three things in HDI. One more thing you should know about HDI is, in HDI the range is 0 to 1 because it is small, 3 letter HDI. So range is also small. And PQLI is big, 4 letter. So the range is also big, 0 to 100. So remember, PQLI have life expectancy 1, then literacy rate and IMR, and HDI have the other thing. Then sometime they ask about in the HDI, what are the maximum minimum limit and what are the things. So in HDI, as I said, one thing is life expectancy at birth. Second is mean year of schooling and expected year. Then there is per capita income in purchasing power parity, triple P. And these are the range. Maximum life expectancy is 85, minimum 20. Mean year of schooling, maximum 15 year you can use in school. And expected is 18. So 15, 18 is there. And then per capita income is $75,000 maximum or $100 minimum. So with these three things, we can derive the dimension. Then we apply this formula, do 1/3 of them, and finally we get the value of HDI. So for India, the HDI is coming as 0.645. That means India is middle level country. So do remember it, these two criteria, and think they ask again and again. The patient does not understand. This is again one question which different platform give different answer. Patient does not understand meaning of doctor word, which type of barrier this is. Some people, they are started telling it as linguistic, semantic barrier and all. But my dear friend, in the NEET exam and in MCI exam also I have seen almost every question come from Park textbook. And they don't want you to answer semantic or linguistic things here. They want you to answer out of these 4 things that is given in Park textbook as barrier of communication. And let's remember it here, because again they can repeat the question and they will repeat the question in upcoming exams. Okay. So when it is difficulty in hearing or expression, that is physiological. Let's say some air is blowing or some sound of dhinchak, some loudspeaker sound is coming. That is physiological barrier. And a physiological means unable to hear or unable to say. Psychological means, let's say you are trying to say something to the patient, but patient is unable to understand because just in the morning someone from the family have died, or he is distressed due to the rape news or other news coming on media. So psychologically the patient is not listening to you. Neurosis, level of intelligence, language or comprehension difficulty, all this can lead to psychological problems, psychological barrier. Environmental means some noise, invisibility, congestion is coming. So if I was talking about loudspeaker, if there is loudspeaker noise, that is environmental, not physiological. Physiological means the person is either deaf, or let's say the person is unable to hear due to some other, let's say cholesteatoma is there, or some problem which is physiological, disease is there. So if due to disease someone is unable to hear, that is physiological. Okay, if due to some environmental factor like loudspeaker or wind someone is not hearing, that is environmental. And if someone is not hearing due to mental issues, mental issue of patient or the person saying, then that is psychological. So disease, mental issue, environmental. Clear? Now in the cultural we have illiteracy of the patient, level of knowledge, understanding, the custom, the belief, religion, attitude, economic and social class difference, and they have clearly written language variation. Now you can see language is coming in psychological also, but they are coming in terms of comprehension difficulty. Comprehension difficulty, unable to comprehend what the person is saying. And cultural is when it is language variation, cultural difficulties between foreigner and national, between urban education and rural population. Okay, so if let's say a doctor is saying something and patient is unable to understand some word, it means there is cultural barrier. The doctor is talking in a, let's say, medical knowledge or English knowledge, and the rural population, due to their cultural barrier, they are unable to understand the language of the doctor. So better answer will be cultural. Okay. And in the psychological, this comprehension difficulty is due to mental illness. The patient is, let's say, having autism or some, let's say, some reason of mental illness is there in the person, and I am unable to communicate my language to the person, then that is psychological due to mental issues and all. Otherwise, if it is simply that the patient is unable to understand the meaning of doctor word, meaning of doctor word is not understood due to cultural barrier, so the correct answer will be cultural. Semantic and linguistic is something which they are not expecting you to answer. They are expecting you to answer out of these four. And anyway, semantic and linguistic both comes under cultural. So better answer will be cultural always. Okay. Now, and I always say it, do not trust expert. Do not trust on what I am saying to you. Trust on evidence. And the Park textbook recent edition is your evidence which you have to follow. And all the pages are being taken from Park textbook latest edition, the 27th one. So do trust on that. What is the marked area in the demographic cycle? So this marked area they have given, if they have given this part, this is the marked area. If they said area is different, line is different. If they say about the line which is below, above line is birth rate, below line is death rate. But if they say the area, this area is showing maximum growth rate. See, what is growth rate? This was the question in MCI exam also. Growth rate simply means birth rate minus death rate by 10. Why by 10? Because birth rate, death rate come in 1000 and growth rate come in percentage in 100. So to remove the extra zero, we divide by 10. So in which phase there is maximum growth rate? Maximum growth rate is in late half of second phase. Dekho bidu. Growth rate simply means the gap between birth and death rate. how many people took birth minus how many people died, that is the growth. So if the gap is maximum, it means growth rate is maximum. It is maximum in late half of second phase. So if they ask this area, that is showing maximum growth rate. But if they say the lower line is representing death rate. Okay. If they say the whole area, then the answer will be demographic gap. Area will be demographic gap. Line will be death rate. Area will be demographic. So if they ask area, better answer will be demographic gap. And that is maximum growth rate. But if they say the line, the lower line, then the answer will be death rate. Okay. So this part is showing maximum growth rate. What is this part? Late half of second phase. The second question they can ask from here is, in which part growth rate start decreasing? So you can see the gap is started decreasing in early part of third. So early half of third phase, this is the part when growth rate start decreasing. And they can ask, what is this green line showing us? So this is showing us the population growth. Okay, the growth of the population is there in the green line. So do remember the two lines. The upper line is birth rate, lower line is death rate. And do remember the two area. Maximum growth rate is in late half of second phase. And when does the growth rate start decreasing? In the early half of third phase, early half of late expanding. Now, in one of the paper, they also asked the correct sequence of event of demographic cycle. So let's read the sequence of event very easily. We can remember it. In the first sequence, there is high stationary. In this high stationary phase, birth rate, death rate, both are high. This was the phase when India was there before 1920-30. A lot of, you must have heard this story. 7 children occurred, 10 died. 4 died, 3 lived, like that. So birth rate is also high, death rate is also high. Then we went into early expanding. In early expanding, birth rate was still high, but death rate start decreasing because medical advancement occur and delivery started occurring in government hospital. Then we entered into late expanding, in which India still belong to this phase of late expanding. And now the birth rate start decreasing. And of course, the death rate, once it start decreasing, it will decrease further. So you just have to remember these two and you will remember the whole of the cycle. Why? Because first one is high stationary and fourth one is low stationary. So in low stationary, birth rate is also low, death rate is also low. So simple to remember. And last phase is declining. Of course, in declining, birth rate become very low. So the population growth rate become negative. So negative growth rate is in declining. Negative growth rate. And if they ask, which are the phases with zero growth rate? So zero growth rate means stationary. First and fourth, they have zero growth rate. First, fourth, zero growth rate. 0, 0. Only remember second and third and you will be able to answer this question. So the next section have this question, that what is the sequence of event? The sequence of event in a demographic transition. Sometimes they call demographic cycle as demographic transition. And so in the transition phase, we start with high stationary, then early expanding, late expanding, low stationary and declining. Okay. So do remember it. Now, is there any question being asked? Few questions came from the last class you took before exam. It helped. Thank you so much. Arusi is saying, thank you, Arusi, for appreciating the effort. And thank you so much. Hi, Krishna, you are there. So in this next question, they are asking that a pregnant lady deliver a healthy baby by normal delivery, earliest time by which IUCD can be inserted is. If they ask the earliest time up to which it can be inserted, answer will be within 48 hours. This is known as postpartum IUCD insertion. Now, if we go to the Park textbook, they have said that we can insert it during menses or within 10 days of beginning of menses, because at that time the cervix diameter will be big and it will be good to insert. And diameter will be big and it is a great time. This is actually a good time to insert. Now, and one more thing is uterus is relaxed and myometrial contraction tend to cause expulsion are at minimum. So this is one thing. Second thing they say related to delivery is that it can be taken up during the first week after delivery, before the woman leave the hospital. So Park has said it that it can be inserted during the first week. During first week. That means at the end of first week also we can insert it. Then they have said that if we are inserting it during the first week, it can lead to perforation. So PP-IUCD is not an ideal time to insert the IUCD. Of course, it should not be inserted within week. There is a chance of rupture. And immediate postpartum, if you will insert, it is associated with high expulsion rate. Because at that time, just after delivery, the size of cervical canal is very broad and therefore IUCD can be expelled out. So they say that a convenient time is post-perpural insertion, and post-perpural insertion is 6 to 8 weeks after delivery. Okay, this is post-perpural insertion. It has several advantages. It can be combined with follow-up examination of woman and her child, because remember, we call maternal death till 42 days. After delivery, if any woman die due to delivery related causes, we call it maternal death. So maternal death is till 42 days. And therefore, when we will ask the mother to come at 6 or 8 weeks, we can confirm that maternal death has not occurred. And at 6 weeks, we also give first vaccines, 5 vaccine doses to the child. So the vaccination will also be done at the same time. So this is there. Now, if there is a first trimester abortion, we can insert IUCD then and there. No need to give a gap. Okay. But if there is a second trimester abortion, we should not insert IUCD immediately. And why? Because there is a risk of infection. So after second trimester abortion, we do not insert it immediately. Now coming back to the question, if suppose they twisted the question and asked maximum time up to which IUCD can be inserted after delivery, answer will be 6 to 8 weeks. Therefore, better answer will be up to 8 weeks after delivery we can insert it. And if they change the question and ask it that maximum time up to which IUCD can be inserted before discharge after delivery, so it can be done up to 1 week after delivery. And this is PP-IUCD is also up to 1 week after delivery, up to 1 week after delivery, before discharge. Because anyway, I hope you must be knowing that under JSSY, we give free food to mother along with free ambulance, free treatment also. So this free food is given for 3 days if it is normal delivery, and it is given for 7 days if it is C-section. So if it is a cesarean section, mother is there till 7 days, and at the end of 7 days we can also insert IUCD. The later we insert, the less will be the chance of perforation. Okay, so they can frame it in 3 ways and ask it in different way. Now, next question is calculate the median of this data. Of course, median is the middle number, and if there is no middle number, we take average of middle two number. Here we can see the middle two number is 4 and 5, and median is always calculated after arranging the number. So after arranging the number, it is already arranged. So we find that 4 and 5 in the center, and if you take average of it, it will become 4.5. So answer will be 4.5. If the data is something else, then answer of course will vary, because some students say that it came 6.5, some said it came 4.5. So it all depends on what is the given data. You just have to find the middle number, and that will be the answer. If there is no middle number, we'll take the average of middle two. And mainly what they ask from here is, sometimes they give a big number at the end, like let's say 89 at the end. So if there is a big number, in that case, which one will be the best measure of central tendency? Best will be median, because median is not affected by big number. Median beech ka hai, and median always remain in the center. It is not deviated by big or small number. Second question they can ask is, if I change 89 with 9, suppose 89 is wrongly written in place of 9. So if you replace 89 by 9, which one will be affected? So the effect will be mean, and mean will decrease. If I change 89 to 9, the mean will decrease, because if it is 89, the average will be closer to 89. If it become 9, then the average will again shift to the center and it will come around 5. So if we change 89 to 9, mean will decrease. Okay. Next question is, following instrument is used for measurement of which of the following? This is Kata thermometer. There are two type of thermometer which has this red color thing. One is Kata, one is globe. Globe will be circular like this. This is globe thermometer, you can see it. And Kata will be long one. Anyway, Kata laga hai na, so the Kata must be long and one. It must be like Kata is a Hindi word which means thrown. So it's long. And what does Kata thermometer measure? It measures two things. It measures cooling power of air, and it also measures low air velocity. If in the option both of the things are given, cooling power and low air velocity both are given, the better answer will be low air velocity. You can see it is measuring cooling power of the air, but Kata thermometer is now largely used as anemometer for recording low air velocity. So now the main use is low air velocity rather than the cooling power of air. Okay, and this is about Kata thermometer, but they can also ask what is wet globe thermometer, silver thermometer. In the next exam, they can ask about these two things. In wet globe thermometer, we measure environmental hit measurement. Now, how much is the hit in the environment, that is measured. And it consists of dial thermometer, which is in the ice line refrigerator also. And it measures hit sensing portion. It is blackened by copper, and basically wet globe thermometer measure the hit, environmental hit. What is silver thermometer measure? Silver thermometer is a reading of air temperature. Air temperature is measured by silver thermometer. And again, Kata, we all know cooling power and low air velocity is measured by it. Now, other than this Kata and all, they sometimes also give sling psychrometer and Ashman psychrometer. So how will you identify it by image? If you will look at the Ashman psychrometer will have like a proctoscope like image, like it will go in someone Asman, it will be totally different. Let me show it to you properly. Okay. So Ashman is psychrometer, and wherever you see the word psychro stands for humidity. So if it is Ashman psychrometer or sling psychrometer, psychro means humidity, they will measure humidity. As sling psychrometer will look something like this, and it has a handle which we hold, and then it revolve in the room like a sling, up down up down up down, and sling psychrometer will measure humidity. Psychro word means humidity, and so is Ashman psychrometer. Ashman psychrometer is something like this, and it's like a rocket and all. And it's, if you look at my name also, it is Ashwani and Ash. So all of these, psychro word itself means humidity. They will measure air humidity. What does globe thermometer measure? Globe thermometer measure radiant temperature of the room. Radiation temperature or radiant temperature, okay, of room. Now, let's discuss about this next question. They have given you this maternal mortality rate thing. They ask that number of maternal death compared with women of reproductive age is known as. So when we compare maternal death with live birth, that is maternal mortality ratio. But when we compare maternal death with number of women who are in that age group, women of reproductive age group, and for how long they are in that age group, person into time, then it becomes maternal mortality rate. Let me explain it better. Park is giving this definition very clearly. When do we call it ratio? Ratio is time maternal death which is occurring up to 42 days after delivery due to delivery related causes. And let's say I am a mother, I just delivered, and after delivery, I put my finger in the shock circuit and then I died due to shock. Is it a maternal death? No. If I died due to drowning, is it maternal death? No. If I died due to, let's say, jumping after delivery, I became depressed that no one is caring for me, I went to the rooftop and jumped from here. Is that maternal death? Yes, that is postpartum blue, which is counted as maternal death. So drowning, electric death, accidental death, these are not maternal death. And it is only up to 42 days which is counting. So we divide maternal death with live birth and multiply with 1 lakh. That is maternal mortality ratio. Why? Because ratio means numerator is not a part of denominator. Is not a part of denominator. For example, we have sex ratio. In sex ratio, we write female by male and then we multiply it with 1000. So are female coming from male? No. Males are coming from female, but females are not coming from male. So numerator is not a part of denominator. That's why it's a ratio. And here also, maternal death are not coming from the live birth. So numerator is not a part of denominator. That's why it is ratio. But what is maternal mortality rate? It is number of maternal death divided by person year lived by women. It's not number of women of reproductive age group. It's person year. How many female are there? How many year they live in the reproductive age group? And all the maternal death, all the mother are from the population of reproductive age group women. Only reproductive age group women can become mother. So mother are coming from the denominator. Numerator is coming from denominator. That's why it is a rate, maternal mortality rate. Okay. And what is the use of maternal mortality rate? It captures risk of maternal death per pregnancy or per birth. And it also compare level of fertility. So maternal mortality rate measures two things. It measures level of fertility and risk of maternal death per pregnancy. Two things is measured by rate. So rate actually means women of reproductive age group nahi, person year lived by women in reproductive age group. This will be the more accurate definition of maternal mortality rate. Maternal death by women, person year lived by women in reproductive age group. Okay. So this is MMR. Now, next question was based on this definition of maternal mortality ratio, which we just said, that all those deaths which occur due to delivery related cause, they will be counted as maternal death and only up to 42 days. And we divide it by live birth multiplied by 1 lakh. Okay. 1 lakh means 50. 1, 2, 3, 4, 50. So here, if you count all the maternal death, how many are? 6 women died, out of which 1 died due to road traffic accident. So road traffic accident is not maternal death. 1 due to sepsis, this is maternal death. 1 due to obstructed labor, this is maternal death. 1 due to eclampsia, that is also maternal death. 1 due to ectopic pregnancy, that is also maternal death. But last one due to snake bite, this is also not maternal death. So total 4 maternal death occur, and live birth given is 4,000. Sometimes they do not give live birth 4,000 directly. They give total delivery as 4,050 and stillbirth. Stillbirth are those deaths which occur between 22 weeks till birth is stillbirth, and they will give stillbirth as 50. So if you subtract 4,050 with 50, it will come 4,000. Mostly they give this data. So anyway, here the data was directly 4,000 given. So if you solve it, this 30 will cancel out these 30, and there is 100 there. 100 is here. So finally answer is 4 by 4 into 100. So 4 by 4 will cancel out, and finally the answer is only 100. That will be the maternal mortality ratio. So this can be solved without calculator. That's why they can ask it again also. This was again a repeated question which already being asked in MCI exam just 6 months back, and they ask it again. And so this is the definition of maternal mortality ratio. Number of female dead due to complication of pregnancy, childbirth within 42 days of delivery from puerperal causes, okay, multiplied by 1 lakh, and it is total number of live birth which is kept in ratio. In rate, it will become number person year of women living in reproductive age group. Okay, sometimes they ask question from direct and indirect obstetric death also. So if the death is due to directly due to pregnancy, labor, puerperium, it is obstetric death, like hemorrhage, hypertensive disorder in pregnancy, okay, anesthesia and cesarean section complication, like air embolism. Air embolism is one of the question being asked, is direct. But when they ask about indirect, indirect can be anemia during pregnancy, okay, death due to aggravation of pregnancy by existing cardiac or renal disease or anemia. These all come under indirect obstetric death. Chalo, now coming to the next question, which of the following vaccine is kept in lowest level in ice-lined refrigerator? So the lowest level will be the one which is most heat sensitive, because if you are heat sensitive, then when we will open the ice-lined refrigerator, fluctuation of temperature will occur and the vaccine potency will be decreased. Vaccine will be less effective. So most heat sensitive will be kept in lowest area. Now, which one is most heat sensitive? You can see directly from Park latest edition, most heat sensitive is OPV. Directly written, OPV is most heat sensitive. Then second number is influenza. Then we have IPV, JE, measles, rubella and all. And the one which is least sensitive to heat is kept at the top, which is hepatitis B, meningococcal, pneumococcal. These are kept in the top. Okay. So how will you remember it? See, in the Park textbook, they have, in the next page, they have written this part, that based on temperature zone, ILR can be divided into two parts, upper and lower part, and all the vaccines should be kept in the basket provided with the ILR. Vaccine like OPV, BCG, measles and JE. OPV, BCG, measles and JE. These can be kept at bottom of the basket. So in the bottom area, we put measles, JE, BCG, OPV and in the lower part. So lower part have 4 vaccines which you can remember, like Maji Bol, Maji means mother, Bol means say, MJ Bol, measles, JE, BCG, OPV. These are 4 vaccines which are in the lower part. But if you ask the best out of them, answer will be OPV, because OPV is most heat sensitive, so it is kept in the lower part. All the vaccine which has tetanus and hepatitis B, IPV and pentavalent, these are kept, and diluent, these are kept in the upper part of the basket. So MG Bol will be in the lower part, and tetanus vaccine, Hep B, IPV, pentavalent, these are kept in the upper part along with the diluent. Okay, so do remember it, and of course answer will become of that question, answer will be OPV, because OPV is the lowest part because it is most heat sensitive. Next question is, if we want to do a case control study on the effect of vitamin C on respiratory disease, what is the correct sequence of event? So first thing we do is we select case and control. After selecting them, we make it sure that case and control are comparable. Suppose in one group you have taken young people, one group who you have taken old age. So then, of course, old age will have more respiratory disease than young age. So your whole study will be wrong. So you have to take those 2 people who are similar in some of their dimensions. Like if you are taking 32-year male with respiratory disease, you have to take 32-year male without respiratory disease as control. Case are those with disease, like respiratory disease is present, and control are those without respiratory disease, who are normal, they are control without respiratory disease. So if the case is 32-year male, control should also be 32-year male. The age should be same, the gender should be same. These 2 things, if we are matching before recruitment, this is known as matching. That will make the study more correct from inside. It will increase the internal validity of the study. Okay, so matching is the second thing which we do. After matching, we measure how much exposure is there, and by measuring we calculate odds ratio, which is also known as cross product ratio, which is AD by BC, I hope you know. So then after measuring the exposure, after taking the history, then we do the analysis. with the help of this odds ratio and cross product ratio. So what does this word measuring total exposure means? Measure total exposure means we take history. So first we recruit case control, then we match them, then we take history, and after taking history we do the analysis with the help of odds ratio and cross product ratio. And these parts are directly written here. After matching we do measurement of exposure, and after measurement of exposure we do analysis. Okay, and of course first step is selecting case and control. Now next question was being wrongly told by teacher in this language. The actual language which student messaged me was that a disease has incubation period of 3 to 14 days. Median incubation period is 10 days. He traveled to countries which require mandatory vaccination certificate. An unimmunized person has to travel in emergency. How many days he will be quarantined? So the duration of quarantine is the maximum incubation period. Try to understand. We do quarantine of those people who look healthy but might be carrying infection inside. So we will keep them in a quarantine zone till the duration of appearance of symptom pass away. And here the maximum duration of appearance of symptom is 14 days. So we will do quarantine till 14 days. Are you understanding it? क्वारंटीन हम तब तक करते हैं जब तक हेल्दी इंसान में जो सिम्टम है, लक्षण है, उसके आने का मैक्सिमम टाइम गुजर ना जाए. एंड द मैक्सिमम टाइम ऑफ अपीयरेंस ऑफ सिम्टम is taken as the duration of quarantine. So what is the maximum time in which symptom appear? Maximum time is 14 days. So we will do the quarantine for 14 days. Answer will be 14 days, not 10 days. So what is this quarantine? I hope you all know this definition. Quarantine is done on healthy people who are suspected of carrying infection, and it is longest incubation period, not median incubation period. Isolation we do on person having disease, and isolation is done till the person can infect other. Till maximum period of infectivity, isolation is done. Till maximum period of incubation, quarantine is done. इसको आप एक स्टोरी से और बेटर समझ सकते हो. मान लो कि आप में से कोई निखिल मान लो न्यूजीलैंड गया अपनी गर्लफ्रेंड से मिलने, और न्यूजीलैंड के एयरपोर्ट पे एक फीमेल डॉक्टर को यह लगा कि निखिल में चिकन पॉक्स के वायरस हो सकते हैं. तो वो उसको कब तक अलग रखेगी? जब तक कि चिकन पॉक्स का लक्षण आने का मैक्सिमम टाइम ना गुजर जाए, जो है 21 दिन. 21 दिन के लिए क्वारंटीन करेंगे. अब 21 दिन हो गए, निखिल निकलने वाला था, बाहर गर्लफ्रेंड वेट कर रही थी, तब एक दाने निकल गए. अब इसको क्या किया जाएगा? आइसोलेट. कब तक? जब तक ये दूसरे को इन्फेक्ट करेगा, पीरियड ऑफ इन्फेक्टिविटी तक, जो चिकन पॉक्स में है 6 दिन. तो अब 6 दिन निखिल वहीं रहेगा, और कोई टेंशन की बात नहीं, इतने दिन में वो डॉक्टर को ही पटा चुका है. अब दोनों दाने से दाने रगड़ेंगे 6 दिन, है ना. व्हाट आई एम टेलिंग यू इज द स्टोरी इज वी विल क्वारंटीन टिल द अपीयरेंस ऑफ मैक्सिमम till the maximum duration of appearance of symptom is there. Like if someone is suspecting chicken pox, in chicken pox quarantine is done till 21 days, and isolation is done till maximum period of infectivity, which in case of chicken pox is 6 days. So if a healthy person is stopped at New Zealand airport, he will be stopped for next 21 days till maximum period of appearance of symptom, and then at the 21 day, if one boil or one pustule come out, he will be isolated for next 6 days, because till 6 days he can infect other. Okay, so this is one thing which we always discuss in classes also. Is not true for incubation period. Incubation period is not used for isolation. For isolation we use period of infectivity. For quarantine we use incubation period. It is done till maximum incubation period. Okay, now there was a very good question. Some of the teacher, they told this question in this way: period between entry and maximum infectivity. If it is entry and maximum infectivity, this is known as generation time. Definitely answer will be generation time between entry and appearance of maximum infectivity. But the question messaged to me by one of my student is, who gave the exam, that many people with disease were studied and maximum infectivity was seen on day 5 from start of symptom. What is this period called? He said this was the language. The language is saying not from entry of pathogen, but from start of symptom till maximum infectivity, what we call this period. And आप story को समझो, and try to understand this thing. Let's say, suppose someone in your batch, let's say Rahul, he sneezed on me. So I will develop first symptom of influenza within 1 to 3 days. Let's say on 2 days I develop symptom. So here entry occurred, entry of influenza pathogen, and after entry on 2 days, I will develop first symptom. So this 0 to 2 days, this become incubation period. Okay. Now, after 2 more days, let's say on 4th day, I became maximum infective. So the period of this part 0 to 4 day entry to maximum infectivity will be known as generation time. Entry to maximum infectivity will definitely be generation time. But if they ask the question between start of symptom till appearance of maximum infectivity, then the answer will not be generation time. The answer will be incubation period. Try to understand this thing. This is the time when symptom appear on 2 days. And if I say from start of symptom till maximum infectivity, start of symptom till maximum infectivity will be only 2 days. Only 2 days. And this 2 day here is the incubation period. So if the question is the start of symptom till maximum infectivity, this answer will not be generation time. This will be incubation period. I know it's very controversial because this definition is not written anywhere, not in Park, not in Harrison, not on Google also. I am searching this definition for last many hours, but I am not finding anywhere this definition written start of symptom till maximum infectivity. Then finally, I did what people usually do when they are hopeless. I opened my chat GPT and type it there. Time gap between first appearance of symptom and maximum infectivity is known as, and chat GPT gave me a clear reply that this period is known as incubation period, not generation time. Generation time is entry to maximum symptom. That chat GPT also agree. But if they ask first symptom till maximum infectivity, then they are saying it is incubation period. And then they are describing it also that in many disease, before the symptom appear, people can become infective. And this period is known as prodromal period, peak infectivity period. Now, of course, incubation period is the time between exposure and appearance of first symptom. This is the definition of incubation period, we all agree. But if they ask first symptom and maximum infectivity, that is also incubation period. Now, Park also hint about it a bit. And Park says about generation time is, of course, generation time is the interval between entry and maximum infectivity. So say they are not saying first symptom till maximum infectivity. They are saying entry to maximum infectivity. Second thing is, they are saying generation time is roughly equal to incubation period. And in many a case, they are roughly equal also. However, these two are not the same, and the time of maximum communicability sometime may occur before incubation period, like in case of mump, before symptom appear, before 48 hours of appearance of symptom, patient start spreading disease to other. So before there is swelling of parotid gland in mump, 2 days before the swelling, patient start spreading mump to other people. So it can be different also in some disease, but I will try to find a better reliable source of evidence. I know ChatGPT is not a very reliable source, but I can say it for sure that if this was the question, maximum infectivity and first symptom, then answer will never be generation time, because already some duration has been passed between entry and first symptom. So it will be half of generation period roughly, you can say, or it will be roughly equal to direct incubation period. And so this definition is not of generation time, is between symptom and maximum infectivity. If they ask, then answer will better be incubation period. And I will come in another YouTube session with proper reference of this. I will find it out in some of the hygiene books and public health books, and I will micro book also, and I will come back to it. This image was being asked. This was the image of Sapna, who is a mascot of Leprosy program. They can also ask you about Meena, which is a mascot of UNICEF program. And Meena was an old cartoon and a school related cartoon come on DD1 previously. And what is Sapna is saying? Sapna is basically saying mascot of Spurs program. Spurs stand for Spurs is this is a mass awareness campaign, है ना, special annual mass awareness campaign, Spurs leprosy program. And this Spurs program, Spurs means healing touch, है ना, in English. So this is basically to reduce discrimination against person affected with leprosy. And Sapna is designed and developed using a common girl living in community who will help spread awareness about the community through key information, education, and communication way. And Sapna can be a local school going girl who is willing to be anyone can become a Sapna who want to spread awareness about leprosy, that you need not to throw the patient out if someone develop leprosy, how to identify it early, and then if they are taking medicine regularly, after 2 weeks of regular MDT, spread of leprosy can decrease and we can accept the patient. If they ask the logo of this program, it is definitely undoubtedly leprosy program. Whenever I teach it, I say that in this program you can see Congress and BJP logo together. There is hand below and lotus above. So if both are there, it is leprosy program. And we say leprosy is eliminated if there is less than 1 case per 10,000. Then we say leprosy eliminated. But if we are talking about elimination of neonatal tetanus or filariasis, neonatal tetanus or filariasis will said to be eliminated if there is less than 1 case per 1,000. Then we say that is eliminated. And for filariasis elimination, we are doing transmission assessment survey, in which if there is less than 1 case per 1,000 for 5 years, we say filariasis is eliminated. Now, if there is a health education model, and first step is awareness, second step is motivation, what is the third step? First, you will make the people aware. Like, let's say you want to spread awareness about coronavirus vaccination. After then you motivate them that if you took COVID vaccination, you will not be able to spread it to your family member. So they are motivated. And after motivation, they will go and take the vaccine. That means they will take the action. So awareness, motivation, action is the health education model which is there. You can see it in the park also. Awareness, motivation, action. So in the awareness, we develop interest. Then in the motivation, people evaluate that I will spend this much money to go to hospital. Is this vaccine is worth it or not? And then they will take the decision after motivation. And then of course, the action can be whether they will take the vaccine or they will not take it. Acceptance or adoption is done. That is action. So this is known as this adoption model. But there is also two other model. One is social intervention model, in which it simply says that it is sometimes the society which need to be changed also. Like if the COVID virus vaccine is available only in city, then many rural people would not have taken it. When the government made it available till PHC, till subcenter, then people took it. So we have to focus on the government work also. Like a lot of people say Indians spit everywhere. It's the problem with the people. But then go to metro. No one is spitting in the metro anywhere. Even if there is no camera, they are not spitting. Because if the system is good and clean, people behavior will change. So this model is known as social intervention model. One more model is medical model, in which we simply give information about disease and we try the people that they will change. So if you are giving information, that is medical model. If you are also working on their motivation, that is motivation model. And then if you are also working on government role, that is known as social intervention model. These are the three models which are known as health belief models and all. These are known as models of health education broadly. Chalo, now let's move to this next question. And they are saying, which of the following is indication for shorter regime of bedaquiline? So when we talk about shorter regime of bedaquiline, we give it in MDR-TB patient. But PARC textbook has directly written this four area where we give bedaquiline therapy. So 4 patients are recipient of bedaquiline. First is only MDR-TB or rifampicin resistance. See, MDR and rifampicin resistance are one, it's not the same thing, of course. MDR means rifampicin plus isoniazid, both resistance should be there. But whenever we find rifampicin resistance, which is being found by CB-NAT test, we directly classify the patient as MDR-TB drug recipient. The treatment which we give for rifampicin resistance is the same which we give in MDR-TB. That's why this is oblique written. Okay. So if someone is rifampicin resistance alone or MDR-TB alone, we don't give bedaquiline. We give bedaquiline if there is with MDR-TB, there is also resistance to any or all fluoroquinolone and any or all second line injectable agent, which is theirs, SLI. Then second definition is when it is XDR-TB, then we give bedaquiline. What is XDR-TB? XDR means either MDR or rifampicin resistance, plus there should be resistance to fluoroquinolone, plus there should be resistance to second line injectable. If all 3 are fulfilled, then we call it XDR-TB. So for bedaquiline, either all 3 are fulfilled or any 2 must be fulfilled. Any 2 out of these 3 must be fulfilled, only then we can give bedaquiline written in PARC. If you go to third line, mixed pattern resistance. Mixed pattern means along with XDR, there is first or second line resistant TB also. And then the fourth is if it is treatment failure MDR plus fluoroquine resistance or XDR-TB. So the minimum least criteria is rifampicin resistance plus any one fluoroquinolone or any one second line injectable. A really good teacher has said that we give bedaquiline if it is MDR-TB. But PARC has written MDR plus rifampicin resistance plus fluoroquinolone or second line injectable should be there. Only then we indicate bedaquiline. Only then we give bedaquiline. Okay. And always trust evidence. Never trust expert, because expert can be biased by their own knowledge. But evidence is the one from where examiner is creating question. Second thing is, when we practice evidence-based medicine, expert opinion is given the least importance and meta-analysis is given good importance, because we do not trust on expert opinion. So what is the answer here? The answer, option Y, rifampicin sensitive TB, of course it cannot be there. Extrapulmonary TB, they are not talking about extrapulmonary TB here. We do not give it on extrapulmonary TB. Rifampicin resistance TB and both 𝐀𝐍𝐒 mutation. So if it is 𝐀𝐍𝐒 mutation, it means it is isoniazid resistance. And for isoniazid resistance, these 2 mutations are there. So if you add this definition, it becomes the definition of MDR-TB. But as PARC has written, it is not given only with MDR-TB. Along with rifampicin resistance, there should be any one fluoroquinolone resistance or any one second line injectable resistance. Then we can give it. So the correct answer will be D. Okay, rifampicin with any one fluoroquinolone or any one second line injectable. Okay, so do check this question very carefully, and I will ask you to go through PARC yourself and check the evidence also. Okay, and this bedaquiline also they can ask again in one more exam. Do remember, how does bedaquiline work? It works by reducing ATP synthetase of the bacteria. The energy house is destroyed, and if we give bedaquiline 1, it will remain up to 6 months after stopping bedaquiline also. After stopping it, even after stopping, next 5.5 months, it will be in the blood. So that's a very good thing about it. And the age of the patient should always be more than 18 years. Pregnancy is a contraindication. We don't give it in pregnancy. And the patient should be using non-hormonal based birth control measure throughout the treatment. Okay, or have been post-menopausal for 2 years. So we don't give it in pregnancy. Someone is using hormonal OCP, then also we don't give it. Someone is using non-hormonal OCP or being post-menopausal, then we can give it. And Cardiac arrhythmia is a problem which can occur with bedaquiline, so we don't give it in cardiac arrhythmia. So do remember these 4 reasons, and only 4 reasons is there in PAR, and no 5th reason is there. So that was a controversial thing. Now, G5P4 lady with 4 female children report for ultrasound scan as per PCPNDT Act. What will you do? Of course, if she is coming for ultrasound, we will do the ultrasound. Do we see the fetus gender or not? Because we will not tell it to the mother. This is a common sense, we all know. But the PCPNDT Act, we will also not see the fetus gender. We will not try to see the fetus gender unless there are some indication. And what are the indications? If you look at the PCPNDT Act, they have given that no prenatal diagnostic technique can be used unless the person qualified is satisfied for reason. What are the reasons under which we can look for sex? One reason is age more than 35 years. Second reason is there is 2 or more spontaneous abortion which has occurred. Third reason is there is potentially tetragenic agent such as drug radiation infection which has been previously given to the mother. Fourth reason is if the pregnant mother or her spouse or family has a history of mental retardation or physical deformity such as spasticity or any other genetic disease, then we check for the sex. And fifth is any other condition which is specified by the medical board, then we can do it. So more than 35 years, previous 2 abortion, taken some tetragenic agent in treatment of cancer or something, or history of previous abnormalities in last child. These can be the 4 reasons, or one extra reason can also be there. Only then we find the sex, otherwise we do not find the sex, we don't see the gender, and we don't tell the woman. So correct answer is option A. Now next question is, a statistician want to study the effect of medicine in 3 groups, human, animal, plant, and then he select randomly out of these 3 groups which sampling is done. So he has divided the participant into 3 groups and then selected randomly from them. If you divide, division means you are creating layer. Layer in English is known as strata. So you are creating layer and then choosing from them. It is known as simple stratified or stratified random sampling. If you are choosing randomly from the 3 groups, then we call it stratified random sampling. For example, let's say I want to take some of the student for a party after the class. What I can do is I can simply by lottery method, I can choose any 10 of you. If I did that, that is known as simple random, because you all are homogeneous, same to each other. So I can randomly choose you. But let's say in that party, I want 5 boy, 5 girl, because you know, I am happily married with 2 children and all, but I want to have more love among you people. So I want to choose 5 boy, 5 girl, so that in that party, they can also have good time together. So I will divide the class into boy and girl, and then I will choose 5 from boy, 5 from girl. This type of sampling will be stratified random sampling. I am choosing randomly 5, 5, but after dividing you into boy and girl. And if I am choosing every 7th student, every nth student, that is systematic random. 1, 2, 3, 4, 7th every. And cluster means if I am choosing all the people who are sitting on the back bench only, that is cluster random. Okay, only one group I am choosing. And that 2 should have common origin. They are not just backbencher, but they are also living in the same wing of the hostel. So that is cluster I have chosen. Cluster sampling is best done in immunization study. Let's say you want to know whether vaccination is more in Bihar or Uganda. So you will choose 7 children from 30 villages and you will compare it this to Bihar and Uganda. I don't know why, but whenever I ask the question, where will you find less vaccination, always students look at me and say Uganda to me. I don't know why. So of course, this is the same way by which we compare it everywhere, and these 7 children are from the same village, so they are cluster which are being chosen. So answer here is stratified, because stratified is done for heterogeneous population which are different from each other, like animal, plant, these are different, so we do stratified random sampling. Okay, it's there. So if let's say they say this question that according to the potential factor that will influence the study outcome, like let's say if you are choosing dividing the population based on their religion, based on their diet, so then and then choosing from them, it's stratified random sampling. These clips which I have taken is from my guest paper, and some question came from there, so I am taking it there. Now, this was one question which we always discuss, that they can ask question on neonatal mortality, perinatal mortality, and again it was also being asked in MCI exam just 6 months back. So live birth is 500, stillbirth is given 12, 9 death in first 7 days, calculate early neonatal mortality. The student told me that this was the real question language. In a population of 30,000, live birth was 500. If 12 died within 28 days, 9 within 7 days, what is early neonatal? So early neonatal, we only include those who died within 7 days is early neonatal. And how many are dying within 7 days? 9. And in all the definition of early neonatal, late neonatal, post neonatal, infant mortality, perinatal mortality, in every of this definition, we multiply by 1000 and we divide by live birth. So how much is the live birth given? 30,000. 30,000. So this 30,000 is the live birth. No. Population is 30,000. That's why they give multiple data. Live birth is only 500, not 30,000. So live birth was 500. This 500 will cut 1000 by 2 and 9 into 2 will become 18. Okay. So the calculation was simple, but let's see this question, which again I discussed in my guest paper thing. And in numerical section also I discussed it, that between 22 week till birth, if someone died, that we call stillbirth. If someone died between birth and first 7 days, we call it early neonatal death, which was being asked here, and this was given 9. If someone died between 7 to 28, that is late neonatal. And if someone died between 28 to 1 year, we don't call it infant, we call it post neonatal. And when we add early, late and post neonatal all together, then it becomes infant death. And neonatal death is only between birth to first 28 days. But what is perinatal? Perinatal means around the delivery. Peri means around, natal means delivery. So perinatal include stillbirth plus early neonatal. Stillbirth if it is 50, early neonatal if it is 150. Then 50 plus 150, 200. And let's say total live birth is 4,000, it will come 50. So like that, we can calculate any one of these. Remember, what is common for all the above? In all of the above, multiplied by 1000 is there, and denominator is live birth. Only numerator is the duration, which is something which you can easily remember by the diagram. You write the death within that duration, divide by live birth, multiply by 1000, and your answer will come. Okay. Chalo, now, what is Sanchol vaccine consist of? So, Sanchol vaccine is, of course, used for polio. Used for cholera. Cholera also have 2 more vaccine: Dukoral, Sanchol, 𝐸𝐸. 3 vaccines are there. And this time they have asked Sanchol, they can change the question later on. So focus here. When it is Dukoral, it is monovalent. And it has, it is monovalent and it is given as 2 doses. See, it is written 2 oral doses is given 7 days apart. So Dukoral is monovalent with 2 doses. Double dose Dukoral, double dose Dukoral. And it is double dose and monovalent. Okay, clear? Now, second thing they have said is that we do not give Dukoral if the age is less than 2 years. We don't give Dukoral. So now let's come to Sanchol. Sanchol and Morvax. These are bivalent oral cholera vaccine based on O1 and O139, and they do not contain B subunit. Therefore, they do not require buffer, and we give it in 2 liquid dose. So Sanchol and 𝐸𝐸, 𝐸𝐸 they pronounce it better. 𝐸𝐸 is same as Sanchol. So Sancol and 𝐸𝐸 both are 2 dose and bivalent. Bivalent and 2 dose. So 2 dose is correct for Dukoral also, for Sanchol also, for 𝐸𝐸 also. Everywhere only 2 dose will be correct. So either of these will be answer. And when it is Sancol and Sancol, answer will be bivalent 2 dose. When it is Dukoral, answer will be monovalent. And if it is UV col also, answer will be same, bivalent 2 dose. Okay, do remember it. Now, let's move to the next question. A patient presented with both Vivax and falciparum infection. If both is there and weight is 50 kg, on day 2, what are the things which you will give? So, I hope you all know artesunate we give 4 mg per kg per day. And this artesunate is given for all 3 days. So the weight is 50 kg. If we multiply 50 with 4, it becomes 200. So if it is 50 mg tablet, we give 4 tablet of artesunate for sure. And whenever it is mixed infection with Vivax and falciparum, we treat it like falciparum. So we will give artesunate 50 mg 4 tablet for sure. Now primaquine, if we are treating falciparum, for falciparum, primaquine dose is 0.75 mg per kg on day 2 only. But if it is Vivax, then the dose is different, 0.25 mg per kg per day, and it is for 14 days. So, which will you follow? We will follow here this 0.25 regime for 14 days. And the weight of the patient is 50 kg. So 50 into 0.25 if you will do, it will come 2.5 into 5. That means 12.5. And 12.5 mg means 2.5 mg 5 tablets should be there. So the correct answer is 2.5 mg 5 tablet. But the student said that only closer option was 6 tablet. So that will be the answer of choice, because in the next they have said 7.5 mg 6 tablet. If you do 7.5 mg 6 tablet, that will be very high, and that's not being given. And on the second day, we do not give sulfadoxine and pyrimethamine. Sulfadoxine and pyrimethamine is only given on day 1. Okay, so that is also not an option. Now let's check it from the park directly. If you can see it, if it is no result available, you don't know what is the patient is suffering from, then we will do blood test with RDT. And if it is mixed infection in northeastern state, we will give of course artemether and lumefantrine. But in non-northeastern state, we give artesunate, and primaquine is given 0.25 mg, not 0.75 mg for 14 days. Okay? So this is the directly from park, and you can see the doses being written. One more thing you can know is the line which they are talking again and again these days in exam. They are asking a lot of questions from the treatment of it. Focus here. When they talk about Vivax, I hope you all know it is total dose is 25 mg, which is divided into 10, 10 and 5. Day 1 10 mg chloroquine, day 2 10 mg, and then 5 mg. And we give primaquine 0.25 mg for 14 days. That is for Vivax. When we come to falciparum, remember on day 1 we give sulfadoxine pyrimethamine, as I said, and the dose is 0.75, not 0.25. But when it is mixed infection, we treat with Vivax dose 0.25 for 14 days. And one more question which they have asked already is artemether and lumefantrine, which we give in northeastern states, is in the ratio of 1:6. So if artemether is 20, lumefantrine is 120 mg, which we give. And if someone went from Assam to Delhi or Delhi to Assam, then we will give artemether and lumefantrine to the patient, because artemether, lumefantrine work all over India. Artesunate do not work in northeastern states because there is resistance to that. So answer will be artemether plus lumefantrine, 1:6 is the dose. And when they talk about malaria in pregnancy, one thing is we do not give artesunate in pregnancy first trimester because it is contraindicated. But in place of artesunate, we give quinine. But if it is Vivax, in case of Vivax, we give chloroquine, because primaquine is contraindicated in pregnant women, in infant, and in G6PD deficiency patient. So if Vivax pregnancy with Vivax is there, we will give chloroquine. Pregnancy with falciparum is there, we will give quinine. Okay, pregnancy with mixed, then we can answer quinine. Okay, So, and treatment of mixed infection, it is clearly written, mixed infection is treated as falciparum malaria. And that's what we are doing, okay? Now, next question is, a patient of HIV is currently on antiretroviral therapy consisting of zidovudine, lamivudine and nevirapine, is diagnosed with tuberculosis. Which of the following TB drugs should be changed in this patient? So, nevirapine, this interfere with the concentration of rifampicin, which is an enzyme inducer. So whenever we are using nevirapine, in place of rifampicin, we should use rifabutine. And second thing is, whenever we are using rifampicin and there is dolutegravir, then dose of dolutegravir should be doubled. Okay? And if it is rifampicin used, in case of, let's say someone is using lamivudine, efavirenz and tenofovir, then the problem is not there. If efavirenz is there, we allow the treatment to continue. This is very beautifully explained by Govind Rai Gaur in his PYQ video. So I am just taking the information from that good teacher. But if it is efavirenz, we will let the concentration remain same. If it is dolutegravir, we will double the dose. Okay. But if it is nevirapine, in place of rifampicin, we will replace it by rifabutine. So these three things you have to know. Okay. Rifampicin is same if it is efavirenz in place of dolutegravir. But if it is dolutegravir, we will double the dose. Next question, and they had given the image of sandfly, which is scientific name is phlebotomus. How will you identify it? If there is wing-like structure, hair-like structure on the body and wing, it is sandfly. Plus sandfly also have very long leg, and we call it phlebotomus. And phlebotomus transmit oriental sore, Oriya fever, and topical and visceral leishmaniasis. Topical and visceral. Visceral leishmaniasis is known as Kala Azar. So it transmits Kala Azar, of course. And to remember the disease, we can simply use the mnemonic. Topical Kala Azar. Topical Kala Azar. Say it with me and you will remember it. Kala Azar. So these are the disease transmitted by sandfly, and I hope you will identify it easily. One of the images they had given was the image of a patient with trachoma. How do you identify it? With this pit, herbit pit. So this is definitely trachoma which is there. If you will go into more detail, this 2-3 things are there. Cobblestone or pavement membrane appearance is there, and then pits are there on the upper part, and this type of image can also be there. Okay, and it is more commonly in African region, the trachoma of the whole eye. In India, it mostly affect upper eyelid, and the drug of choice which we give is azithromycin 1%. And I hope you will remember the safe also. We do surgery to correct the trichiasis first, then we give antibiotic, then F is not for fuck off, face wash, and E is for environmental cleanliness. Mostly it is caused by chlamydia trachomatis. Typically we give it by azithromycin. Okay. Then if one of the question was, there is a chronic hepatitis B patient with active viral replication. So what are the various biomarkers which will be there? So this is a very good table given in PARC, which can be used to answer these questions which are being asked again and again. One thing is, if it is acute hepatitis B, then IgM will be there when we are talking about anti-HBC. HBC means core antigen. Na? Core antigen is not released, it is only anti-core antigen which is there. So anti-core antigen, if it is IgM, it is acute. If it become IgG, it can be chronic if it is along with HBS. And if you find HBE, HBE is indicating active viral replication. If HBE is absent, it means viral replication is low. So if it is active viral replication, of course HBS will be there, surface antigen will be there, IgG will be there for chronic, and anti-HBC will be there, and HBE will also be there if it is active viral replication. If it is not active viral replication, low viral replication, HBeAg will not be there. Then in case of vaccination, vaccination will have anti-HBs. So that means, this was the question in NEET exam, in the recombinant vaccine, which component is used for hepatitis B virus? HBs antigen we use, S antigen we use, plus DNA. This is the composition of vaccine. That's why the anti-HBs will be present in the blood of the patient for vaccination. If it is recovery, recovery will have IgG and anti-HBs, which indicate that immunity has come. Okay, and if it is false positive, then only IgG will be there, anti-HBs will not be there. That means it is false positive. Okay, if it is acute hepatitis B, in acute hepatitis B, anti-HBC will be IgM type, like here, acute hepatitis B, and sometime HBs can be there, sometime it is not there also, and HBE also can be present or absent. But main thing you have to remember is, if HBE is there, it is active replication. If HBeAg is absent, then it is low viral replication. Okay, and therefore, if it is chronic hepatitis with active viral replication, they are saying it will have HBsAg plus it will have HBeAg plus it will have anti-HBc AG IgG type. Then this is active viral replication chronic hepatitis. These three things will be there. I hope this table will help. And there is one more chart which tell that first of all the things which appear is HBsAg, it appear first. After HBs, the second thing which appear is HBeAg, is the second thing which appear. Then after HBe, in the blood anti-HBc occur, and then it remain for even if it is chronic infection, it will be there. And when HBs goes down, then anti-HBs goes up, and when HBe goes down, then anti-HBe is there. This table is also very useful from PAR. Next question is, which of the following is best iron deficiency indicator in population? So that is the saturation level of transferrin, which tell best iron deficiency, because sometimes the hemoglobin level is normal, but the storage of iron has depleted. This is known as latent iron deficiency, hidden iron deficiency, and the transferrin saturation, it fall from normal 30% to less than 15%. If transferrin saturation is low, then we can simply say that we can, with the transferrin saturation level, we can detect anemia which is hidden in the society. Okay, so it is most widely prevalent stage in India is low saturation of transferrin. Okay, do remember. Now, saturation of transferrin is the best way. And when do we call it anemia? In male it is 13, in female it is 12, but in pregnancy it is 11. So 13, 12, 11, male, female pregnancy, like that you can remember. They have given this logo of yellow color mother, yellow color child, that will be Janani Shishu Suraksha Karyakram. Okay. There are 6 logo in which mother and child are there, and we can very easily remember all the 6 logo by the color coding. If it is green color logo, green color mother, green color child will be Anmol, which is a tablet based software for recording and reporting of high risk pregnancies by A&M. If it is white color mother, white color child, that is foreign, it means baby friendly hospital initiative. If it is black color mother, black color child, then it is Laksh program, which is for upgradation of maternity ward, maternity OT and labor room. If it is incomplete mother and child is indicating an incomplete program, PM Matru Vandana Yojana, in which previously 5,000 is given, now 6,000 rupees is given, 2,000 at 12 week when mother come for first ANC checkup, next 2,000 at 6 month pregnancy, and last 2,000 at 6 week after delivery. If you found it yellow, as I said, yellow is Janani Shishu Suraksha Yojana. I call it in all the class like this, that it has Sisu who keep on doing Susu. So due to Susu, it become yellow. And if you found it blue, blue color mother and child is for UNICEF, which also funds seed and manure of applied nutrition program. So these 6 logo, you can easily remember, mother child are there, but with the color you can remember it. So these are all the 45 questions which I was able to gather through different areas. I hope this discussion will help you not just in this exam, but in upcoming exams also. So I have taken more time than any other person in explaining PYQ, but I was explaining the whole topic. I hope it will be useful. Thank you so much. Love you all. Hasta la vista. Das vidania. Thank you so much. Bye bye.